Kia ora koutou, my name's Campbell Brebner. I'm the primary care medical advisor at Counties Manukau and a GP by background. And I've been asked to come and talk about clinical variation with respect to diabetes. And I just need to start this off by saying I am not an expert in clinical variation. So you don't need to expect anything overly erudite or intellectual. It's just that Sue happened to see me present some slides on variation in diabetes care in Counties Manukau once, and so thought it would be a good idea for me to come along and talk a little bit about it. But what I hope I will achieve perhaps today is just to be able to stimulate a little bit of reflection by you all, and maybe even provoke some action about what is a significant issue, I believe. So I'm going to assume that you all have a bit of an understanding about clinical variation. It's not a hard concept to understand. I think it's pretty reasonable to say that there's a growing body of evidence to suggest that the presence of variation in healthcare leads to increased inefficiency, decreased effectiveness, increased chance of harm for people, and a whole lot of other things. And this slide really is designed to it's a bit of a complicated slide. I'm not going to go through it, don't worry particularly. It comes from the King's Fund. But it really is by way of pointing out that there's a whole lot of different drivers behind clinical variation. It's very well accepted, of course, that there is good variation and there's bad variation. So not all variation is undesirable. But the difficulty, as that quote there says, is in reducing that bad variation, which reflects the limits of our professional knowledge. So that's the first point I want to make. Not all variation is undesirable. The second point I want to make is that it's endemic. We've already saw a variation slide from Nairi earlier about falls and rest homes, and I just wanted to make the point that it's not just, it doesn't just happen in primary care, it doesn't just happen for diabetes. This is showing variation in admission rates for a couple of surgical procedures across the country, and as you can see, the different colours obviously indicate different rates, and there's quite substantial variation district to district. So that's the second point I need to make, is that it is an endemic issue. So in terms of understanding variation, data is key. And that's the third point I want to make, that it is imperative that we get good data so that we can drill down and understand what is causing variation. What this is showing is that, I don't know if you guys have heard of the virtual diabetes register. Yes? No? Okay, so there's this central ministry list of all the NHIs of people who've got diabetes. And what we're now doing in Auckland is we're extracting primary care data, with your permission, I've got to say. Not everybody's given permission at this stage, and we are collating it, and this is for diabetes and cardiovascular disease, and we're putting it into a a repository called HealthSafe, so it's nice and safe and it's secure and it's private. And we did a comparison between our calculation of how many people have got diabetes and what the virtual diabetes register is telling us. And it appears that at a high level, so at a PHO level, you can see the concordance is actually quite good. But when we drill down into practice level, which is down here, there's a whole lot of practices who've got either way more diabetics registered than the virtual diabetes register suggests they should have, or way fewer. So at that level, there's considerable variation, which is problematic. So what I thought I'd do now is just quickly step through some of the components of diabetes and see what levels of variation. Firstly, the detection of diabetes. Well, we're probably doing okay, and probably in large part because of the More Heart and Diabetes Check program, which you've all been involved with, and you're all diligently screening people for their cardiovascular risk and for diabetes. But even there's a bit of variation. So this was the latest results that came out at the end of 2016. So it shows that there's a sort of a variation from about 92% success with the screening program right down to 87 down in Canterbury. I hope they don't mind me naming them. So there's a bit of variation there, but we're doing pretty well. And so the Virtual Diabetes Register suggests we have about 40,000 people with diabetes currently in Counties Manukau. And I've just got to make the point, this data that I'm about to present is largely about Counties Manukau, and I apologise to those who aren't really interested in Counties Manukau, but you're just going to have to put up with it, I guess. So the second sort of step is, are we monitoring our HbA1cs? And so this is showing the various DHBs across the country. And by the way, this data comes from the Health Quality and Safety Commission Atlas of Healthcare Variation. Are people familiar with that? Not a lot of. So it's quite an interesting place to go and look. Actually, there's all these interactive kind of graphs and maps and things that you can look at, and I find it interesting, but I might be a bit of a geek. I don't know. So this is Counties Manukau. So this would suggest that here that in Counties Manukau, compared to other district health boards, we're monitoring people with diabetes pretty effectively. But again, you can see that there's it appears to be quite a bit of variation from below 75% right the way up to probably close to about 90% there. Are we screening for complications? Well, in Counties Manukau, again, we seem to be pretty good at that. We're the best of the pack. Again, a huge amount of variation. Sorry, this end's not showing up very well by the looks of it, but across the DHBs, quite a lot of variation still exists. Perhaps less so for monitoring for renal disease. Counties Manukau, we can be pretty proud we're doing a good job there. We're monitoring our diabetics on a regular and ongoing basis. That's fantastic. Are we managing their complications? Probably not quite so good in comparison to other areas across the country. And my question, of course, is, well, why is that? Why the heck are we screening for the stuff and not doing anything about it when we find it? I don't have an answer to that, by the way. It's just a question I have. So we then move on to saying, are we, what's this one about? This is prescribing. So Counties Manukau happens to be the highest prescriber of metformin for its people with diabetes. That's a good thing. But when it comes to prescribing insulin, we are almost bottom of the pack. So it's a really good thing that there's a talk coming up, I believe, on starting insulin, which I hope everybody's going to understand by the end of today. Again, the question has to be asked. So when we drill down further, we can look below DHB level into the PHO levels, and we can see that there's a bit of a variation amongst our PHOs in terms of their screening, with some up around the high 90s or mid 90s there, right the way down to the low 90s. There's not a lot of variation in that particular activity, though, interestingly enough, and it's because there's money behind it, of course. Are we, again, at a PHO level, are we monitoring our people with diabetes? And this is where the data becomes so important. And you can see this particular PHO. It appears over 30% of their diabetics are not being monitored. That's what this is saying. So even amongst the others, there's quite a bit of variation. So this is people who haven't had an HbA1c recorded in the last 15 months. About 4% perhaps in pro-care practices, and as high as perhaps 14% in total healthcare, but that is almost certainly a data issue, and we know that because, and I'm not meaning to be critical here, but some PHOs are more mature with their data capabilities than others. So coming down to practice level with respect to HbA1c monitoring, and again we see substantial variation occurring. So there's a whole bunch of practices out here who are screening everyone regularly and effectively. So they've got no people with diabetes who haven't been screened. And then we've got one who doesn't screen anyone, and I don't actually believe that. And I suspect that one also, there are going to be data quality issues there. But probably the remainder are valid. And it would be pretty sad to think that 30% perhaps of your diabetics are not getting regular monitoring. And I mean, when I say regular, I mean once every 15 months isn't actually all that regular, I suppose. How do we go at managing diabetes? This is showing Counties Manukau practices and the percentage of their people with diabetes who have an HbA1c below 65, and you can see that there's one practice down there who has only got about 25% of their people with diabetes well controlled, and others who are up over the 80% mark. And there's a lot of factors that sit behind this, and it's really important that this isn't about judging. But usually when you see an extreme, there's going to be some component of unwarranted clinical variation that sits there. Prescribing of insulin for people with poorly controlled diabetes, massive amounts of variation here. And it may well be that there's data issues at the lower end, I acknowledge that. But I don't think that's going to explain all of it. There's a massive amount of variation, and it kind of fits with what we were seeing the pattern before and at a rolled up DHB level, that in counties there's something about us not getting our people onto insulin when we should be. Reno protection, so this is the prescribing of the Reno protection medication, ranges from sort of mid to high 40s all the way through to as much as 100%. So again, quite substantial variation practice to practice across Counties Manukau. This isn't all of Counties Manukau practices because some are not submitting data at this stage, or we can't get the data. Just a quick look at the variation that occurs across ethnicities for the various components of care. We see that there's variation between, in terms of effective control of diabetes, Pacific and Māori around about the 50%, whereas Europeans up around 70%. And I've been given the time, so I have to move on quickly. Microalbuminuria, big differences between the various ethnicities. I won't bother with that one because of time. So, yeah, at the beginning I said I'd like us, I'm hoping I'll stimulate some reflection. All I guess I'm asking out of this is, what's our responsibility in all this? How much of that is due to us and us not, and us over-servicing or under-servicing or whatever it happens to be, not following best practice guidelines, etc. And then I guess, what is it that each and every one of you can go out and do tomorrow, or if not tomorrow, on Monday morning? Thank you.